I'm about to tell you something that may genuinely surprise you, something that could protect your health, or the health of someone you care about. My name is Dr. Noah Grant. After more than 2 decades as a cardiac surgeon, I've treated countless older adults whose most dangerous medical problems weren't caused by diabetes itself, but by the treatment of diabetes. I've seen elderly patients brought into the emergency room confused, sweating, barely conscious. Some were found on the bathroom floor in the middle of the night. Others arrived with heart rhythm problems triggered by a sudden adrenaline surge, and nearly all of them were taking their medications exactly as prescribed. They were trying to follow their doctor's instructions. They were trying to keep their A1C under 7%, because that's what they'd always been told. But here's the part most people never hear. Targets designed for younger adults aren't always safe for frail seniors. The A1C goal that protects a healthy 50-year-old can actually increase the risk of harm in someone over 75, especially those living alone, those who are frail, or those on multiple medications. Yet many people are still being treated as if lower is always better, even when that approach puts them in danger. This isn't speculation. Large studies and updated professional guidelines show that overaggressive blood sugar lowering increases the risk of hypoglycemia in older adults, leading to falls, injuries, hospitalizations, and in some cases, life-threatening complications. But many patients never hear this. Some clinicians hesitate to change long-standing habits. Others simply don't realize how much risk hypoglycemia carries for someone in their late 70s or 80s. By the end of this video, you'll understand why low blood sugar can be more dangerous than moderately high blood sugar for older adults. What happens in the brain and heart during hypoglycemia? Why an A1C target below 7% is not appropriate for every senior. And how to talk with your doctor about safer, individualized treatment goals. This isn't about giving up control. It's about choosing the right level of control, one that balances benefits with real-world safety. Martha's story. Martha was 79 when her daughter called me, terrified. Martha had fallen at 3:00 a.m. and broken her hip. She'd always been careful, used a walker, moved slowly, avoided risky situations. So what went wrong? Her medical chart told the story. She'd lived with type 2 diabetes for 15 years. She was taking metformin, 2,000 mg a day. Glipizide, a medication that increases insulin release. Insulin glargine, a long-acting insulin, 25 units at bedtime. Her most recent A1C was 7.2%. To get her below the traditional target of 7%, her insulin had been increased 2 weeks earlier. That night, she ate a smaller dinner than usual. She took her medications, went to bed, and woke up in the early hours feeling dizzy, weak, and confused. When she tried to stand, her legs gave out. She fell and fractured her hip. When paramedics arrived, her blood sugar was 48 mg/dl, a level low enough to impair brain function. This wasn't bad luck. It wasn't clumsiness. It was hypoglycemia caused by a treatment plan that was too aggressive for someone her age. What was happening in Martha's body? The brain depends almost entirely on glucose for fuel. When blood sugar drops below 70 mg/dl right arrow, early symptoms begin. Below 60 mg/dl right arrow, thinking, balance, and coordination decline. Below 50 mg/dl right arrow, severe neuroglycopenia. The brain is starved of glucose. Martha experienced confusion, poor coordination, and weakness, all classic signs of neuroglycopenia. Tasks that were normally simple, standing, walking, reaching the bathroom, became dangerous because her brain wasn't receiving enough fuel to control her body. For a younger, healthy person, this is usually frightening but temporary. For an older adult, it can be catastrophic. Falls can lead to fractures, loss of independence, long hospital stays, and complications that dramatically affect quality of life. And the tragedy is that this kind of event is often preventable. Even when a fall doesn't cause immediate death, The aftermath often becomes life-threatening. Older adults who fracture a hip can face weeks of immobility, and that immobility increases the risk of pneumonia, blood clots, infections, and a decline in overall function. Many patients never fully recover. But the danger of hypoglycemia doesn't stop at one fall. Repeated low blood sugar can harm the brain over time. A landmark study published in JAMA Internal Medicine in 2013 followed more than 16,000 older adults with diabetes for 12 years. Their finding was striking. Seniors who had severe hypoglycemia requiring emergency care had more than double the risk of developing dementia compared with those who never experienced severe lows. Let that sink in. Repeated episodes of low blood sugar were strongly associated with long-term cognitive decline. Why? The mechanism is straightforward. The brain relies on glucose as its primary energy source. When blood sugar drops too low, neurons become underfueled. Brain function becomes impaired. And with severe or repeated episodes, some neurons die. A single hypoglycemic episode rarely causes obvious brain injury, but years of recurring lows add up, gradually contributing to memory problems, cognitive decline, and eventually dementia-like syndromes. Unfortunately, these patients are often diagnosed with age-related dementia, and no one realizes that years of overly intensive diabetes management may have played a role. This is one of the major problems with obsessively targeting an A1C below 7% in older adults. A1C is an average, and averages can hide dangerous extremes. Two people may both have an A1C of 7%. One may range safely between 80 and 220 mg/dl. The other may swing between 50 and 250 mg/dl. The average is the same, but the second person is experiencing episodes of blood sugar low enough to be hazardous. This is exactly what happened to Martha. Her A1C of 7.2% appeared well controlled, but she was having frequent, unreported lows, shakiness, weakness, episodes she assumed were normal for diabetes. She didn't realize she was experiencing hypoglycemia severe enough to damage her brain and increase her fall risk. That's the first mechanism. Hypoglycemia causes immediate neuroglycopenia that leads to falls and long-term cumulative neuronal loss that increases the risk of cognitive decline. But there's a second mechanism, one that can be even more immediately dangerous for seniors with heart disease. The adrenaline response, why lows trigger cardiac events. When your blood sugar drops, your body doesn't passively wait for the brain to fail. It launches an emergency counterregulatory response, a surge of adrenaline, noradrenaline, cortisol, glucagon, growth hormone. These hormones work together to rapidly raise blood glucose. Of them, adrenaline plays the biggest role. In young, healthy adults, this system works smoothly. But in older adults, especially those with coronary artery disease, this hormone surge can be dangerous. Adrenaline increases heart rate, increases blood pressure, makes the heart beat harder, raises the heart's oxygen demand. For a healthy heart, this is manageable. For a heart with narrowed arteries or weakened pumping ability, this sudden stress can tip the balance toward a heart attack, a dangerous arrhythmia, or cardiovascular collapse. A large meta-analysis published in Diabetes Care found that severe hypoglycemia was associated with roughly double the risk of cardiovascular death in diabetic adults, especially older ones. This isn't theoretical. I've seen it firsthand in the cardiac ICU. An elderly patient comes in with a heart attack. When you trace back their symptoms, they often describe feeling shaky or weak earlier, classic signs of a low. That hypoglycemic episode triggered an adrenaline surge, destabilizing a coronary plaque and setting off the cascade that led to the heart attack. The tragedy. The hypoglycemia is rarely recognized as the trigger. The patient is treated for the heart attack, but their diabetes regimen stays the same. They remain at risk for another event. Martha was fortunate. She didn't have a heart attack during her low, only a fall. But many patients aren't so lucky. The bigger picture. Hypoglycemia is dangerous because it attacks from two fronts. The brain, causing confusion, falls, and long-term cognitive decline. The heart, triggering stress responses that raise the risk of heart attacks and arrhythmias. Yet for years, medical training has focused almost exclusively on lowering A1C, on preventing complications from high blood sugar, without fully acknowledging that low blood sugar can be just as dangerous, and often far more immediate. Thankfully, guidelines are beginning to catch up. Organizations such as the American Geriatrics Society and the American College of Physicians have updated their recommendations, emphasizing individualized, safer, less aggressive glucose targets for older adults, especially those who are frail, living alone, or managing multiple chronic conditions. These updated guidelines finally acknowledge what research has demonstrated for years. In older adults, especially those who are frail or managing multiple chronic conditions, aggressive blood sugar control can cause more harm than good. Instead of a single universal A1C goal, the new recommendations emphasize individualized targets that reflect a patient's overall health, functional status, and risk of hypoglycemia. For healthy older adults, people in their 70s who remain active, independent, and cognitively intact, an A1C goal of 7% to 7.5% is considered appropriate. These individuals generally tolerate modestly tighter control, and the risk of severe hypoglycemia is lower. But even for this group, the target has shifted upward from the old, below 7% mess. Age. The slight relaxation reflects a growing recognition that perfect control is not necessary, and that striving for it can introduce avoidable danger. For older adults with multiple chronic conditions, limited functional reserve, or reduced life expectancy, the recommended A1C range is 7.5% to 8.5%. This represents a major departure from older guidelines that pushed nearly all patients toward a single lower target. An A1C of 8.5% corresponds to an average glucose of roughly 200 mg/dl, once considered poor control. But for a frail 85-year-old with heart failure, kidney disease, or cognitive impairment, that target is often safer than an A1C of 7%. It significantly reduces the risk of hypoglycemia while still avoiding extreme hyperglycemia. The reasoning is simple. The complications of chronically elevated blood sugar, retinopathy, neuropathy, kidney disease, develop slowly, often over a decade or more. When someone's life expectancy is limited by age or comorbidities, aggressively pushing blood glucose lower to prevent complications far in the future makes little clinical sense. Doing so exposes the patient to immediate risk, hypoglycemia, falls, or cardiac stress, to prevent problems they may never live to develop. Yet many clinicians continue applying younger adult targets to older patients. Why? First, clinical inertia. For decades, A1C under 7% has been the universal mantra. When a message has been repeated for that long, changing practice patterns takes time. Second, fear of criticism. If a complication develops and chart notes show an A1C of 8%, clinicians worry about being accused of undertreatment, even if that higher target was safer. Third, lack of personalization. Assessing functional status, comorbidities, fall history, and hypoglycemia risk takes time. Applying a single target to everyone is faster, even if it's not safer. That's exactly what happened in Martha's case. Her endocrinologist saw an A1C of 7.2% and reflexively aimed for under 7%. But Martha was 79, frail, living alone, and at risk for falls. Instead of evaluating her individually, he adjusted her insulin dose to chase a number, without recognizing that her control was already more than adequate for someone in her situation. The result was a preventable hypoglycemic event and a broken hip. So what should have happened? First, her doctor should have recognized that an A1C of 7.2% in a frail 79-year-old living alone was excellent control. There was no reason to intensify therapy. In fact, reducing medication might have been the safer choice. Second, Martha should have been educated about the signs of hypoglycemia and encouraged to check her glucose whenever she felt symptoms like shakiness or weakness. She had been experiencing mild lows frequently, but she assumed those sensations were just part of diabetes. Third, a continuous glucose monitor, CGM, would have helped uncover the overnight lows that her A1C value was disguising. For older adults at risk, CGMs can provide life-saving early warnings when glucose begins to fall too low. This brings us to the core of safe diabetes care for seniors: de-intensification. De-intensification simply means adjusting medication doses, or in some cases reducing the number of medications, to lower the risk of hypoglycemia while accepting a modestly higher A1C target. This approach is supported by major geriatric and internal medicine societies, but it must be done under medical supervision. Patients should never discontinue medications on their own, but they can and should advocate for an individualized plan. So here's the simplified protocol. Safe diabetes targets for older adults. If you're over 75 and generally healthy, active, independent, and cognitively intact, your likely target is A1C 7% to 7.5%. If you're over 75 and frail, managing several chronic conditions, have a history of falls, or have cognitive impairment, your likely target is A1C 7.5% to 8.5%. These ranges are not signs of giving up. They're about choosing the level of control that protects quality of life and reduces real-world danger. These targets help prevent extreme hypoglycemia while still maintaining safe glucose control. This is something to actively discuss with your doctor. Bring a copy of the American College of Physicians guidelines and ask, given my age and health status, what should my A1C target realistically be? Are we being too aggressive with my current treatment? Most physicians are very open to this conversation when you frame it as evidence-based individualization rather than a desire to stop diabetes care. You're not avoiding treatment, you're tailoring it based on current medical understanding. Identify high-risk medications. Some diabetes medications cause hypoglycemia, others don't. Medications that can cause hypoglycemia include insulin all types, sulfonylureas, glyburide, glipizide, glimepiride, meglitinides, repaglinide, natglinide. These drugs force insulin production or ensue insulin action regardless of your actual blood sugar level. If you eat less than usual, exercise more than usual, or get sick, they can push your glucose to dangerously low levels. Medications that do not typically cause hypoglycemia include metformin, GLP-1 receptor agonists, semaglutide, dulaglutide, SGLT2 inhibitors, empagliflozin, dapagliflozin, DPP-4 inhibitors, sitagliptin, linagliptin. These work through mechanisms that don't force insulin production when it isn't needed, making them far safer for older adults. If you're using insulin or sulfonylureas, ask your doctor. Can we reduce the dose of these medications, or switch to alternatives that lower my hypoglycemia risk? Often doses can be reduced dramatically, and sometimes the medication can be stopped entirely, especially if your A1C is already lower than necessary for your age and health. Sometimes simply switching from a sulfonylurea to a DPP-4 inhibitor maintains similar glucose control without the hypoglycemia danger. Implement continuous glucose monitoring. A1C is only an average. It hides low blood sugar episodes. Continuous glucose monitors, CGMs, track your blood sugar every few minutes around the clock. They reveal patterns, show drops you don't feel, and warn you before symptoms begin. Medicare now covers CGMs for people using insulin. Even if you are not on insulin, CGMs are available and extremely useful for detecting hidden lows. A 2-week CGM trial can uncover information that years of A1C results completely miss. You might discover your glucose drops into the 50s every night at 3 a.m. You experience daily afternoon hypoglycemia that has gone unnoticed. This data lets your doctor adjust your medications based on real evidence instead of guesswork. Ask, can we use a continuous glucose monitor to check if I'm having unrecognized low blood sugar? Most endocrinologists strongly support CGM use because the data is so valuable. If your doctor is hesitant, request a referral to an endocrinologist who specializes in diabetes care for older adults. Follow the bedtime safety rule. The most dangerous time for hypoglycemia is overnight. You're asleep. You can't feel symptoms. You can't treat yourself. Your glucose can drop dangerously low for hours without you waking up if you wake up at all. Severe nocturnal hypoglycemia can lead to seizures, coma, or death. This is why some diabetics are tragically found dead in bed in the morning, undetected overnight hypoglycemia. The bedtime rule is simple. Never go to bed with a blood sugar below 110 mg/dl. If your bedtime glucose is under 110, eat a small protein and fat snack. A tablespoon of peanut butter. A piece of cheese. A handful of nuts. These provide slow-release glucose through the night and help prevent dangerous drops. If your blood sugar is under 90 at bedtime, eat a larger snack and discuss reducing bedtime insulin with your doctor. Also be very cautious with evening alcohol. Alcohol blocks your liver from releasing glucose during a drop. If you drink alcohol at night and then take bedtime insulin, your risk for severe nighttime hypoglycemia increases dramatically. Either avoid alcohol in the evening or make sure you significantly reduce your bedtime insulin dose on nights when you drink. Alcohol suppresses the liver's ability to release glucose, which dramatically magnifies hypoglycemia risk. Many severe nighttime lows happen in people who drank earlier but took their usual insulin dose. If you drink, plan for it, adjust for it. Treat it as a medical variable, not a casual detail. Recognize hypoglycemia early and treat it correctly. You must know the symptoms of low blood sugar. They are warning sirens your body sends before things become dangerous. Shakiness. Sweating. Rapid heartbeat. Anxiety. Dizziness. Confusion. Weakness. Hunger. Irritability. If you feel these symptoms, check your blood sugar immediately. Don't assume. Don't wait. Don't dismiss it as just anxiety or just hunger. If your blood sugar is below 70 mg/dl, treat it at once. Use the rule of 15, the universal standard. Consume 15 grams of fast-acting carbohydrate, 4 glucose tablets, 4 ounces of juice, 1 teaspoon of honey. Regular soda, not diet. Wait 15 minutes. Recheck your blood sugar. If still under 70, repeat. No guessing, no delay, no maybe it will come up on its own. Don't overcorrect. Many people panic during hypoglycemia and eat everything they can find: cookies, bread, candy, leftovers, anything within reach. They consume hundreds of grams of carbohydrates in minutes. Their blood sugar skyrockets to 250 or 300. They feel awful from the rebound high. Then they take extra insulin to fix the high. That insulin causes another low later, and the roller coaster continues. This cycle of spikes and crashes is far more damaging than stable, slightly elevated sugar. Treat lows with precision, not panic. Measure, wait, recheck, repeat if needed, that's it. Review your medications regularly. Diabetes evolves over time. Your body at 65 is not your body at 75 or 85. As you age, kidney function declines. Liver function slows. Medications take longer to clear. Appetite changes. Physical activity decreases. Hormonal responses weaken. Doses that were perfect 10 years ago can become dangerous today. Many older adults continue taking the same regimen they've been on for decades, even though their body's needs have changed dramatically. Insulin doses stay high. Sulfonylureas stay on the list. Medications accumulate. Rarely do doses get reduced. This is the opposite of good care. Schedule a comprehensive annual medication review with your doctor. Bring every medication you take, prescriptions, over-the-counter drugs, supplements, herbal products. Discuss which medications are still necessary, which doses can be reduced, which drugs increase hypoglycemia risk, whether non-hypoglycemia medications could replace dangerous ones. Many older diabetics suffer not from undertreatment but from overtreatment. Their regimen was intensified year after year, but never scaled back as age, health, and physiology shifted. This is therapeutic inertia in reverse, the failure to reduce treatment when needed, and it is just as harmful as failing to treat at all. Overtreatment kills. Understand the U-shaped mortality curve. Research repeatedly shows a U-shaped relationship between A1C and mortality in older adults with diabetes. Mortality is high when A1C is extremely elevated, above 9–10%. But mortality is also high when A1C is aggressively low, below 6.5%. Why? Because tight control dramatically raises the risk of severe hypoglycemia, especially in elderly patients whose counterregulatory responses are weaker. The lowest mortality, the bottom of the U, consistently occurs around A1C 7.080%. Not 5.8. Not 6.2. Not the numbers often targeted in younger, healthier adults. Moderation is safer, stability is safer, avoiding extremes is safer. A major study published in Diabetes Care, 2010, examining over 70,000 older diabetics, found that those with an A1C below 6% actually had higher